Lexic. I'm an MSL with Natera's Organ Health. Today I'd like to present on a paper called Outcomes of Kidney Donors with Sickle Cell Trait, a preliminary analysis. This was written by researchers from Houston Methodist and was published in Clinical Transplantation in 2022. I want to discuss this paper not only because of the findings that they present, but also because of the wider discussion about sickle cell disease and trait in the world of kidney transplantation. To begin with, I'd like to cover some of the basics about this disease. Sickle cell disease is a recessive condition caused by mutations in both copies of the beta globin gene, HBB. It causes abnormal hemoglobin to accumulate in red blood cells, making them change shape into a sickle, and this defective shape causes all sorts of vascular complications. Sickle cell trait is the term for someone who is a carrier of sickle cell disease, meaning they only have one mutation on one of their HBB genes. Usually we think of carriers as not being affected by the genes that they carry, but in this case the carriers are well recognized to be at risk of various symptoms, including chronic kidney disease progressing to end-stage kidney disease. In African Americans, the prevalence of sickle cell trait is about the same as the prevalence of the APOL1 high-risk genotype. Additionally, the risk of advancing to end-stage kidney disease is almost identical in both groups. Traditionally, there has not been consistent, uniform screening for sickle cell trait in living kidney donors, and only 34% of transplant centers currently test for it. However, the prevalence of sickle cell trait is underrepresented in donor populations, as seen in the database from which the current study is drawn from. In non-donor populations, there are renal risks associated with sickle cell trait, such as hypertension, decline in eGFR, and risks of developing end-stage kidney disease. What is not known, however, is the risk that sickle cell trait confers to kidney donors, and KDIGO has recommended recently that investigations be done into this population and their outcomes. This study aims to do exactly that. In this study, the short and long-term outcomes were measured for kidney donors with sickle cell trait. These patients were gathered from the ReLive database, which included 8,922 patients from a University of Minnesota database. There were 17 live kidney donors in that group who were known to have sickle cell trait. These patients had donated organs between the years of 1963 and 2007. These 17 patients represented all of the sickle cell patients that could be found in that database with sickle cell trait. Patients' medical records were consulted and surveys were sent to each participant. Each patient was matched with 4 controls who were similar to them in age, gender, ethnicity, weight, eGFR at time of donation, related versus unrelated donation status, study center, and year of donation. Of the 17 patients with sickle cell trait, 9 were African American, 2 were white, and 2 were of unknown ancestries. And in the short term, the outcomes of both these donors with sickle cell trait and their matched controls were very similar in terms of post-operative hematocrit, need for ICU admissions or blood transfusions, and the volume of interoperative blood loss. No significant differences were found in these short-term regards. In terms of the long-term outcomes, patients were measured after about 18 years, plus or minus 10.5 years. And the outcomes that they were looking at were very similar, again, between the cases and the controls, specifically for the risk of hypertension, cardiovascular disease, and decline in eGFR. These were all very similar. The only difference between the cases and the controls in this situation was proteinuria, which had developed much more commonly in those with sickle cell trait, with a relative risk of more than 5. Sickle cell disease is known to cause characteristic vascular lesions in the kidney, and sickle cell trait is also known to cause certain lesions, although to a much lower extent than sickle cell disease is. However, there is very little literature that's actually measuring the performance of the outcomes of donors with sickle cell trait. We do know that individuals with sickle cell trait have about a 2 times increased risk of advancing to end-stage kidney disease. Several other large meta-analyses have also shown the difference in outcomes of people who are non-donors living with sickle cell disease or trait, and consistently we're seeing that risks of advancing kidney disease are highest in those with sickle cell disease, a moderate amount in those in sickle cell trait, and of course population levels for those without either. There's little consensus for who and when to test for sickle cell trait. In fact, 18% of centers would say they would not consider a candidate to be eligible for organ donation if they had sickle cell trait, even though the CDC does recommend that these individuals can donate organs. In fact, 96% of African American donors say they would like to know their APOL1 status prior to donating, even though 61% of them say that this might not prevent them from considering organ donation if they were found to be positive. And the comparisons between the attitudes towards APOL1 testing and sickle cell trait testing are valid because these share a similar prevalence and an almost identical risk of kidney disease in the African American population. The authors actually were able to calculate the potential impact that could be had by excluding donors with either APOL1 high-risk genotype or sickle cell trait. Based on known donor demographics, population prevalences, and the relative risk incurred by each one of these genotypes, it was calculated that there could be 10 donors who could have been prevented from progressing to end-stage kidney disease if those without sickle cell trait had only been allowed to donate, and another 14 donors could have been prevented from progressing to end-stage kidney disease if we had excluded donors with APOL1 high-risk genotypes. These data raise an interesting question of what risks and rewards we're willing to take when we're accepting donors who may themselves be at risk for an increased amount of kidney disease after their donation. This study had several limitations that the authors pointed out. For example, the small sample size of 17 patients. There was also few serial serum creatinine draws able to be available based on the long-term follow-up on these patients. An uncertain testing protocol made it a little bit unclear who exactly had or did not have sickle cell trait versus those who either had or did not have sickle cell disease. And finally, of course, it's supposed that these 17 donors who were allowed to continue with their donation, even though they were known to have sickle cell trait, were most likely selected for and very enriched for patients who were in good health without other serious complications. So these results may not be able to be transmitted into a population-wide prediction of the outcomes. Thank you very much.